to get things started, I'd like to go ahead and introduce today's speakers. Today, we're lucky to have Matt Wynn joining us. He's a vice president in our National Health and Analytics Group, and Jason Jossi is in our health practice as a vice president. He's also a consulting actuary. And to kick things off today is Eric Miller. He's a vice president in our National Health and Analytics Group. Eric, it's all yours.
Thanks, Chris, and appreciate everyone joining us today to go over the 2025 survey. This is our agenda for the hour. Our survey report includes both summaries from the survey responses and some additional insights that we gleaned from our own data warehouse, which we call SHAPE. We like trying to provide some of that additional context and add depth to the numbers rather than just saying, hey, the trends are expected to be about 8%. But that said, the trends are expected to be about 8%, at least for the medical PPO trends. We're expecting a 7.9% for 2025 and 11.4% for the prescription drug trends. And note that this view is actuals for 2016 through 2023. So this portion here is actual data. And then we're showing the projections from the survey for 2024 and 2025. Now, the way to read this, or the way that I read this, is not to fixate specifically on the 7.9% or the 11.4%, but more to think about the direction and magnitude of those numbers relative to recent history. So I think the signal being sent from the industry is more that there's no expectation that these trends that we're seeing will moderate in 2025. Or to say that another way, you could think of the things that are driving trends today are expected to continue driving trends into 2025. And so it's that signal that I think about more than specifically those numbers. And I do think this drug trend is a little bit interesting at 11.4%. We'll go into some more detail around really each of these numbers shortly, but I wouldn't be too surprised if some of this ended up being a bit optimistic. And on that note, this next slide here compares prior projections, which is this dark blue line, with actuals. So the actuals, again, this is what we were showing on the previous slide, and then this is what the projections for those years past were for the medical PPO. And you'll notice a few things from this chart. And first is just the tendency to be conservative, tendency to overestimate, which isn't too surprising that survey responses for future years would be conservative. So you tend to see this gap. And then, of course, the second thing that just jumps out at you is the pandemic. Of course, people weren't expecting in advance prices to go down in 2020. And then you had this sort of roller coaster jumping back up in 2021. And then 2023 is really the first year where the actuals are starting to look more like that pre-pandemic experience. And I think the other big takeaway from this, and this purple line here at the bottom, or is at the bottom until you get to 2021, this is the CPI, this is inflation. And so I don't know if you followed the news very much, but there was some inflation coming out of the pandemic that we saw in 2021 and 2022 here. And I think that this is really the main thing that's driving trends in healthcare today and expected to continue having an effect in 2025. It's just that for a couple of years here, everybody was feeling squeezed, having higher cost of doing business and trying to raise their prices. And it takes time for prices to increase in healthcare, and then for those prices to be implemented at the point of service, and then for the accumulation of all of that to be visible in historical claims data. So there's a long lag between people wanting to raise prices in healthcare and actually seeing it show up in the data. And so I think that is part of what we're seeing here is a broad upward pressure on prices. And again, I think the expectation in the industry is that we're still a bit early in that, and we'll continue to see it into 2025. And then also notice here the 7.9% is in itself a bit significant if I jump back to these actuals, you'll see that aside from the 2021 COVID rebound year, that this would be higher than any of the year's actuals by a good bit, by a full percent. So this is kind of an elevated level, that 7.9%. So let's talk a little bit about some of the macro drivers of trend. And I won't go through this whole list. This is kind of a standard list. In some years, certain items will be more impactful than others. We already talked a little bit about medical inflation. But I do think it's worth talking about the population. And this says aging population, but I think you could think more generally of just changes in the population. So certainly there is an aging population, and there is a rise in obesity or a rise in acuity. But there's also some dynamics related to younger workers being more interested or having a greater focus on mental health services. I think we see that in a lot of clients' data. And of course, coming out of the pandemic, I think most everybody was experiencing higher trends in mental health. And some of that is access, greater access in the virtual setting. But I think some of that also is just changing preferences within the workforce, that younger workers, this is something that they value, that mental health care access more than perhaps prior generations. And then jumping down here to regulatory changes, I think that kind of fits in down here as well. The example is the No Surprises Act, but very recently, as you may or may not be aware, the NQTL regulations, that's non-quantitative treatment limits for mental health parity, was finalized just recently. And this is going to be a big effort for plans in 2025, trying to substantiate compliance and considering what changes they may need to make. And that may cause some of those trends in mental health to continue. Some costs or utilization may increase as a result of changes to meet those regulations. We'll have to see what happens there. And then I would also highlight health provider consolidation here. I don't know if you guys can actually see me highlighting that, but I think this has been one of the big stories of the last 5, 10 plus years in healthcare as a whole, is just consolidation and acquisitions by venture capital or private equity moving into the healthcare space. And it's well understood, this effect in terms of prices, of upward pressure on prices from consolidation. But it also changes things like billing patterns and practice patterns. There's been some stuff just lately in the news related to office visits that get facility fees billed and things of that nature. So this has had a very profound effect in a lot of markets. But that said, the experience plan to plan, of course, will vary based on geography, based on the makeup of the plan. Of course, high cost events, catastrophic events, outliers is going to vary by plan, but also the decisions that each plan makes related to their provider network, their vendor partners, plan design features, cost management programs or point solution programs. All of this will have some effect on trend, on magnitude or timing. So there will be some variance just plan to plan. And we're going to go into that very soon, showing some of what that variance looks like, giving some sense of that variance, which again, I think is nice to see that spread instead of just the 1 point estimate, which is what we captured in the survey. So with that, I'll turn it over to Jason to dive a little deeper into the medical trends and to give us some insights of what we see from our data warehouse. Jason?
All right, thanks, Eric. And hello, everyone. Hopefully everybody can hear me all right. So I'm going to be taking us through our next few slides. We're going to look at some more results from our survey, but then we're also going to look at some trends that we're seeing within our own client base. But first here, we are looking at what our survey respondents anticipate medical trends in the commercial market looking like in 2024 and 2025. There does seem to be some general consensus that medical trends are going to be about 1% higher in 2025 compared to 2024. That is pretty significant. I don't think I've seen a jump like that, at least not in recent memory. And Eric mentioned this before. Part of this is just newly negotiated provider contracts. Medical care was a little insulated from some of that high general inflation we saw during the last several years. and that's due to multi-year contract agreements in place. But those are coming due, and we're starting to see some upward pressure on medical trend. We have been anticipating this, so it's nothing too surprising. It's maybe taken a little longer than we expected, but nonetheless, this is not a surprise by any means. But here we're looking at how that trend breaks down by different types of medical plans. So just starting on the left here with high deductible health plans, these are projected to have the highest trend rate in 2025 of 8.3%. That's up from 7.5% in 2024. PPO plans are expected to have a 7.9% increase in 2025, and the largest jump from 2024 of over 1%. And then lastly, HMOs all the way to the right, they're projected to be much more stable, increasing about 0.2% up to 7.8% in 2025. And we can move on to the next slide, please. All right, so now we're looking at medical trends in Siegel's Shape Data Warehouse. And that's just to get a better idea as to what our clients are actually experiencing, and also the range of trend within our client base. For those of you who are not familiar with Shape, it is Siegel's data warehouse. We have data for many of our corporate, public sector, multi-employer clients in there. And with that data, we do a lot of data analytics that can provide insights into the quality of care members are receiving, what's driving healthcare costs, how networks are performing, that sort of thing. But how to read this chart is the dark blue line, that's the 50th percentile across our client base. And the gray shadow around it, that's the 25th to 75th percentile. So we can really kind of get an idea of not only the median trend rate, but also the volatility over the last few years here. We also do have a dotted turquoise line, and that's just the historical trend rate over that whole experience period. So we can see trends for medical have been very volatile during the last few years. That's just due to the pandemic, of course. We did reach a low point at the end of 2022, and it's really been steadily rising since then. By the end of 2023, about half of our clients, in our data warehouse at least, did have medical trend exceeding 6%, and about a quarter of the clients in the warehouse had trend exceeding 9%. So a lot of plans are experiencing high post-pandemic trend. I wouldn't really expect this to abate anytime soon. It seems likely we're going to see medical trends just kind of continue to slowly rise through next year. And that is what's reflected in our survey results as well. We can move on to the next slide, please. All right, so here we're looking at projected medical trends for Medicare. One very important thing to note here is that this is for gross medical trends. So it doesn't include things like CMS funding, member cost sharing, or anything like that. And CMS funding really covers the vast majority of costs on the Medicare side. So there's a lot of disconnect between gross trends and what net trends actually are. So I just wanted to point that out. But overall, gross trends are projected to be pretty stable. All the way on the left here, we have PPOs. The anticipation there is that trend rates are going to remain slightly below 5% and not really change from 2024. Our survey respondents are expecting a slight rise in trend for Medicare HMOs from 4.5% to 4.9%, and a similar increase for Medicare supplement plans from 4.4% to 5%. One thing I'll say here is that trend in the Medicare Advantage market, it's just a lot different than the commercial market. It's highly dependent on star ratings, which, if you're unfamiliar, they're awarded based on a system CMS uses to evaluate vendor quality and quality of care provided through that vendor. It's also heavily influenced by risk scores within a covered population and the vendor's ability to capture those risk scores. But any change in star rating or risk adjustment revenue can really heavily influence the net trend that's actually paid by a plan. So just something to keep in mind. If you're seeing Medicare trends that seem kind of disconnected from what we're seeing here, there's a lot of other levers and moving parts going on that could be causing that.
And then Jason, just real quick, this is also just to highlight, this is the change in expense. This is the claims change. This is not what you would expect to see in premiums, just to really emphasize that point.
Yeah, exactly. Yep. Thanks, Eric. Let's move on to the next slide here. So here we are looking at ancillary benefits. I believe this is our only slide on ancillary benefits, which covers dental and vision. We are seeing some interesting movement on the dental side. Nothing too exciting on the vision side at this time. But on the dental side, the fee for service plans, are expected to have a trend rate of 5%, which is up from 4% in 2024. So that's a pretty significant jump, and certainly higher than dental trends we've seen in the several years now. And then moving right along here, dental provider organizations are expected to have a lesser increase, but still fairly significant for dental, increasing from 4% in 2024 to 4.5% in 2025. And then dental maintenance organizations, trend is expected to be more stable there, increasing 3.5%, which was consistent with what the expectations were for 2024. The last two groupings there are both for vision. A small trend of 1% is expected for schedule of allowance plans. And for reasonable and customary plans, an increase of about 3% is expected. And vision trends have really been around 3% for several years now, so nothing too surprising happening there. All right, so now the next few slides we're looking at are going to focus on prescription drug trends, and this is really where it starts to get a lot more exciting. One important caveat here is that these are gross trends, just like everything else we'll be looking at. So this does not include the effective rebates, but we are seeing a significant increase in trend expected on the commercial side. Drug trends are expected to increase from 9.9% in 2024 up to 11.4% in 2025. I think the reality here is that drug trends in 2024 are already in the double digits. At least that's what we're seeing with most of our clients. So most plans aren't going to see a jump like this is suggesting. But when we did receive those 2024 projections, it was really before the state of the GLP-1 market was clear. So I think a lot of vendors were just kind of underestimating the impact that those drugs are going to have. But either way, drug trends are expected to be in the double digits through next year on a gross basis. A lot of the drugs that are driving this high trend we're seeing should be heavily rebated. So actual plan trends should be lower than what we're seeing here once those rebates are taken into account. But that's not a guarantee, of course. You always have to look at where the rebates are coming in and make sure they are increasing like they should be. Another thing to note here is that specialty drugs, which is all the way on the right there, drug trends actually expected to decrease from 14.5% to 13.3%. So still a significant increase, but we're finally starting to see some relief on the specialty side. The main driver of trend recently has actually been brand drugs. And that's a reversal from what we've seen for many years now, where it's really been specialty drugs driving drug trend. Now we're starting to see those brand drugs, which have a much bigger pool of utilizers. Those are actually driving trend more than specialties. One of the main deflators we're seeing in the specialty drug market is the arrival of biosimilars. Those should offer a lower net cost, and that's for some of the priciest drugs on the market. So that should provide some relief to plans. But we are seeing a lot of trend volatility within our clientele. Any given plan's drug trend, it's really going to come down to, how successfully can they promote biosimilar utilization, how aggressively can they negotiate their PBM contract, and then also how well can they control GLP-1 utilization. The last thing I'll cover on this slide is just a middle section, which pertains to the Medicare market. Medicare drug trends are expected to decrease slightly from 7.5% to 6.6%. Again, this is on a gross basis, which is even more meaningful on the Medicare side. It doesn't include the CMS revenue, member cost sharing, rebates, anything like that. There are a few things on the Medicare side that are worth noting. One is that CMS now has the ability to negotiate drug prices, starting with 10 of the most common drugs out there. That doesn't actually take place till 2026, so it's not really affecting what we're seeing here. But it will be interesting to see how that change is going to affect Medicare trends in the near future here, and also trends on the commercial side. But when we give this webinar next year, that should become a lot more clear. So what the impact there will be. But the big changes in the Medicare drug market for 2025 are the removal of the coverage gap, and then also the implementation of a $2,000 out-of-pocket limit for plan participants. Both of these should be causing upward pressure on the net trend that plans are actually going to pay. However, what we've been seeing is that CMS has actually increased the direct subsidy for 2025 as well. And a lot of times it's offsetting what the additional plan costs would have been from those other changes I mentioned. So it's probably going to be a little more neutral than we were expecting just because of that increase in the direct subsidy, which is, good news for plans and plan sponsors, of course. For the next slide, I'm going to pass over to Matt, and he'll take us through a few more prescription drug slides.
Real quick, I just want to jump in and clarify one thing that Jason said there about specialty drugs driving trend instead of brand drugs. And what he was thinking of there is the standard traditional 4-tier formulary. And so the specialty tier being separate from brand drugs. And that was what that comment was about. Not necessarily, I mean, brand drugs can be specialty drugs, but that's what he meant was brand non-specialty.
Yeah, just thanks for clarifying. Right. Yep, exactly. Thanks, Eric.
Okay, great. So now we'll pivot over to our pharmacy data within our Shape data warehouse, where we were previously talking about trends on the survey. So kind of like Jason showed before, here we're showing you the rolling 12-month change in allowed pharmacy PMPM for the months between 2021 to 2023, similar to how Jason showed for the medical side. So the median pharmacy trend never went negative like you saw with medical. Medical dipped below, as low as -5%, but pharmacy, that never happened. The median trend shown as that solid dark blue line only dipped out to about 5%, and then it's been, increasing ever since then. In the period ending in 2023, median trend was 11.3%. So when Jason talked about the trend survey and how they were predicting 2025 trend being 11.4% or so, we're already there based on end of 2023 data. So that's what a lot of our plan sponsors are seeing. The shaded region, as Jason talked about, is our 25th to 75th percentile trend range. And that gives you an idea of the common trends experienced by the plan sponsors within our Shape data warehouse. On the low end, ending 2023, the trend at the 25th percentile was around 7.8%, which is right in line with the historical trend of 8.6%. But on the high end, the 75th percentile reached 16.3%. So if you put that in context, that means a quarter of the clients that were in our Shape data warehouse have trend above 16%. Many are in the 20%, honestly, and we're seeing a lot of that continue to rise into 2024. So on the next slide, we'll look at specifically what is driving some of these trends. So unsurprisingly, as you are pretty much all aware of, diabetes medications are the main culprit. As I mentioned, the median trend was 11.3% at the end of 2023. And diabetes itself impacted overall pharmacy spend by 4.6%. So essentially 40% of the trend is specifically due to diabetes medications. Now for comparison, the next 4 indications, which include things like psoriasis, autoimmune disease, skin disorders, and obesity management, totaled 4.9%. So diabetes as itself is equivalent to those 4 other indications. Now, while the indications of psoriasis, autoimmune disease, and skin disorders are really driven by those high-cost biologic agents, typically all of which are specialty medications, diabetes and obesity management is mainly driven by non-specialty. So Ozempic, Mounjaro for diabetes, Wegovy, and Zepbound now for weight loss. Other 2 key areas that we're tracking closely is oncology, where we've seen spend increase on not just pharmacy, but also the medical, but migraine as well. And migraine is one to really keep an eye on. And it's similar to diabetes medications, which had a bunch of new drugs come out within the last 5 or 6 years. Migraine has had the same experience. We're seeing brand medications come out to replace those older, generic drugs that have been around for decades now, and really replace those in line for therapy. So for example, for migraine prevention treatment, historically you were using generic drugs that were technically not FDA approved, but well studied for prevention. Now there are brand name medications available for migraine prevention. They cost anywhere from $400 up to $1,600, depending on which one you're using. We're not only seeing higher cost here, but also an uptick in usage because these preventive medications initially came out as injectables that can be administered typically by the member themselves or the patient themselves. But now you have a number of oral medications available, which makes it more attractive to many individuals with migraines that have an aversion to injections. So there's a lot of variation in cost here. Up until recently, we did not have any kind of robust clinical studies comparing these newer brand name medications head to head, but now we're starting to see that. So that will help advise plan sponsors on which drugs are the best to use and try to do a cost benefit analysis. So next, we'll look more specifically at diabetes and obesity management, which I know is very common and top of mind for many people. And just as a reminder, these two categories combined drove half of the pharmacy trend that we're seeing. So what you're seeing here on the left is the allowed PMPM for GLP-1 medications indicated for diabetes. And then on the right, that same kind of PMPM trend on pharmacy for anti-obesity medications, or the GLP-1 specifically. So on the left, you see that for the quarterly PMPM from 21 through 2023, that initially the diabetes PMPM was about $5.40, and that has since more than tripled at the end of 2023 to $16.80. On the high end, the 75th percentile is about 50% higher, nearly $24 PMPM. And a lot of our plans, the plans within our SHAPE database have trends above that even into 2024. On the right, though, you see that the PMPM for weight loss versions of these medications is much lower, on the verge of less than $1 a couple years ago in 2021, and only rising to $6.50, versus the $16.80 you see for diabetes. But these numbers are likely understated. Many plan sponsors added anti-obesity GLP-1 coverage at different times, and right now, plan sponsors are heavily evaluating different programs and cost management strategies in this area that may kind of ebb and flow utilization for this area. That said, again, many plans have GLP-1 spend for anti-obesity well over $20, equaling that of diabetes spend. Right now, I would say about maybe half of our clients cover anti-obesity medications and the other half do not. And on the next slide, we'll kind of look at how that has impacted their pharmacy trend. So yeah, at the moment, about 50% of our clients in SHAPE cover weight loss medications. The others do not. So the trend for those clients that cover the medications is shown in dark blue versus those that do not is shown in the turquoise color. And you can see that for clients that cover the GLP-1s for weight loss, you see that the overall relative trend has been consistently between around 7 and 9%. And then that spiked dramatically into 2023. And if you think back to, what could have been the triggering point, if you remember the Q4 2022, that's when Ozempic and Wegovy, even though Ozempic's not technically approved for weight loss, were heavily, a buzz on social media platforms. And that really drove a lot of the increase that we saw in 2023. Conversely, though, diabetes spend has been, steadily rising from 5.6% to 12.1% for the GLP-1s there. Part of that is more robust clinical studies showing the overall benefit of these drugs. A lot of this has also changed to the American Diabetes Association guidelines in 2022 and a little bit earlier leading up to that, that put these drugs as first-line therapy options for many patients with diabetes. So, that said, we've seen in our data for plans not covering, there's been usage, though, of GLP-1s for diabetes off-label. This is the power when you have the whole picture of not just pharmacy, but medical data as well. You can look at members that are getting, GLP-1s for diabetes that might not actually have a diagnosis of diabetes and may actually have a diagnosis of obesity. And in some instances, we've seen a third of utilizers using these diabetes medications not actually using them for diabetes. So ensuring appropriate utilization in general is just one area that can help manage overall cost. And Eric's going to go into some strategies with a focus on the medical benefit next.
Thanks, Matt. And as we pivot to fade there, so we pivot to talking about some of these cost management strategies, I first want to just answer one of the most common questions that I get on these reports, which is how much are employers planning to pass along to their workers, and how much are they planning to absorb, or how much can they absorb? Now, of course, this will vary, but by and large, the feeling is that the labor market is still a bit tight, and employers are not planning to, or not in a rush to pass along these costs to their workers. We hear much more from clients on how to manage and how to mitigate these types of costs than interest in just wholesale passing them along. And I think that's been the way that we've been seeing it for several years now. And we're not really seeing those attitudes change just yet. So moving into the top cost management strategies that were identified from the survey. And so again, this is a ranking from the survey. This is not necessarily a recommendation from Siegel specifically. But what's noteworthy here compared to prior years is just how much of a focus and emphasis has been placed on prescription drug cost as opposed to medical costs. So in the prior year survey, 4 out of the top 5 here were all medical based strategies. And the only one that I made the top 5, I think, was about managing the drug formulary. But now, this year, 4 out of the top 5 are related to drugs. And even the 5th one here is related to condition management, which certainly has some motivation in drug costs. Certainly obesity and diabetes are on people's minds when they're thinking about things like digital health coaching. But I don't think there's any surprise that 1 and 2 here are related to weight loss medications, GLP-1s, like Matt was just discussing. And I think that this is just, like we said, this is in a state of flux. I think employers are trying to figure out what the optimal use of these medications is, how they fit in with the larger strategy on managing obesity. And so I think that's what we're seeing here by these being just top of mind, is just figuring out what's the right way to use these. And it's not just should we cover them, yes or no, but how to cover them. How can we align these effective medications? How can we align that with the right risk to achieve the best outcomes, in a way that's still still cost effective. And then I think here it's worth also emphasizing this point about biosimilars. Matt mentioned this just a minute ago, but it's a well-needed spot of optimism, of downward price pressure. And I think this has been something that's had unrealized potential for many years now. For many years, you've been hearing that biosimilars are about to have a really big effect on drug costs, and it hasn't really come to fruition. But I think we really are starting to see it now. I think we're really starting to realize some of that potential from biosimilars, and the expectation is that will grow, that will continue. And I do think that perhaps that's part of why projected drug costs aren't even higher. Why they aren't even 50. I think they probably are still understated. But I think people have some real optimism around biosimilars, and that's guiding some of their thinking there. So now for a little bit more.
Actually, Eric, just to add to that one, there's kind of a misconception, I would say, in terms of the impact of biosimilars, because many people just think about the pharmacy benefit and the drug side specifically. But biosimilars have been around for a decade now, beginning in 2014 on the medical side. And, you should be, if you aren't already, seeing a lot of savings there, pushing price down, not just on the price of the original product, but the biosimilars have kind of come down in unison with those as that pressure has increased. So we are seeing it on the medical side, and hopefully we'll see that same impact on the pharmacy side.
Yeah, that's a great point. Thank you for jumping in with that. And I think that covers this slide. So now for a little bit more on the medical side, specifically from our perspective, a little bit more, I'll hand it back to Jason.
All right, thanks, Eric. Yeah, so what Eric was just going over was from our survey respondents, but now we're going to get into Siegel's top 5 medical cost management strategies. There has been a little bit of a change from last year. Eric mentioned this already, but we no longer have revisit plan design as a top strategy. It might be due to the tight labor market, other things going on in the macro economy, but most of our clients, they want to offer competitive benefits, and we're not seeing much of a push to push more costs onto the actual plan participants. I will say though, it's always a good idea to revisit things like fixed copays, and also adjust the plan design to help incentivize either lower cost sites of care, cost efficient treatment options, and also cost efficient drug utilization. But either way, that's no longer in our top 5. But we do have revisiting network strategies as a top strategy. Again, that's been a top strategy among our clients for a few years now. Plans just seem more inclined to implement a narrow network to control costs rather than pushing more costs onto the plan participant. It at least gives them an option to save money on their end while receiving similar quality care. Both of the ones on the bottom, so enhancing behavioral health and high cost claim and case management, Those have also been strategies the last few years in the post-pandemic environment. Mental health, it's kind of like obesity in a way. It's a very common comorbidity, and it has a lot of tertiary effects that I think we're really just beginning to understand now. And it's really becoming clear that when you treat the mental health condition, other physical conditions tend to improve as well. And vice versa, when you ignore the mental health condition, it's really hard to have an impact on the physical chronic condition. So it's not something plans can really ignore, just given how prevalent it is. There's much more awareness. The infrastructure is really built up over the last few years. And I think we're starting to understand that these conditions can be very costly if they're left untreated. And then for high cost claimants, this is just a reality that all plans face. You can focus on improving population health, and it can help mitigate some high cost claims in the future. But in the near term, plans really should be focusing on improving case management. And that can include things like identifying high cost claimants, engaging them in case management and improving ways to engage them, reaching more of the population, and then also establishing treatment plans for those who've been identified as a high risk. And then new this year is eliminating fraud, waste, and abuse, or FWA. That's the one in the top right. And then we also have early detection and prevention of cancer. Cancer is it's a top cost driver on the medical side. It's also a top cost driver on the pharmacy side. It's becoming more prevalent in the population. Some cancers are even occurring in younger and younger ages, especially colorectal cancer, which is one of the more common ones. But we do see that usually about half the cancers diagnosed in the populations that we cover do have recommended screenings for early detection. And these recommendations are always changing. So it's really important to communicate these changes to plan participants when they do happen. But beyond just early detection of cancer, I would say plans should also focus on improving cancer treatment. This can include things like offering second opinions, healthcare navigation and guidance, and then also identifying centers of excellence for cancer treatment when it does arise. And then the last one I'll talk about, the fraud, waste, and abuse, or FWA. This estimate can vary a lot, but about 25% of healthcare spending is due to fraud, waste, and abuse. So there really can be significant savings for plans if they can find ways to identify it, reduce it, and just help their plan run more efficiently. And I just think the improvements in data analytics and the capability there to actually identify fraud, waste, and abuse, and also costs are slowly becoming more transparent with new regulations in place. I think that's why we're seeing this enter the top 5 cost management strategies. And I'd expect it to be a big focus in the coming years. It's finally getting a little easier to identify this stuff. It's not easy, but there's just so much there where plans should have a focus on it. And then I will pass it back to Matt. Take us through the next few slides here.
Thanks, Jason. Yeah, so regarding pharmacy, here are a few strategies plan sponsors can consider and employ. For plan benefit design, there are many plan benefit design changes that can be considered and implemented, but one we're seeing clients consider is moving away from the low dollar fixed copays on the pharmacy side because of the rising cost of drug therapies. While there has been more hesitance to do this on the medical side, the reality is that brand medication may have been $500 a couple years ago, and it's now $1,000. As the higher cost medication use increases, not adjusting copays results in cost increases being the sole burden of the plan sponsor. A couple years ago, Junivia was the main medication used in diabetes at about $400 a month, compared to say $800 to $1,000 for Ozempic or Mounjaro. With a fixed $25 preferred brand copay, for example, the entire $400 additional cost is absorbed by the plan sponsor. So, switching to a higher copay or possibly a coinsurance can also lead to more cost-conscious plan participants. Modifying PBM contracts can be, pretty basic. It's something as like ensuring that definitions are clearly defined. So this could be what exactly is a brand or a specialty medication that we just kind of talked about earlier in the presentation. With so many biosimilars now, what is a high cost versus a low cost biosimilar, because that will impact greatly rebate guarantees and so forth. These definitions need to be based on defined parameters that can actually be verified and are not subject to just a third-party administrator's interpretation. This can be done using something like publicly available data, the FDA Purple Book, for example, that tells you biologics and if something's an originator or a biosimilar, or a standard drug database, whether that be, one of the two big ones, like Metaspan or Affairs Databank. Other areas, are formula management and leveraging low-cost drug therapies, and these really, they just go hand in hand. For formulary management, that should ensure that the lowest cost but equally effective, if not more effective, therapeutic option is available, while the higher cost and potentially less effective options are non-preferred. Relatedly, unlike historically with generic drugs, biosimilars, which are highly similar copies of a biologic medication, are potentially rebate eligible. So while, Humira biosimilars might have list prices that could range from as low as 5% to as high as 95% of that Humira, rebates also need to be accounted for to find the lower cost therapeutic option. And then finally, for clinical controls, I'm actually going to talk about that, in the purview of obesity management on the next two slides. So while a key topic, is obesity management and GLP-1 therapy with Wegovy and Zepbound, keep in mind that drug therapy, when it is indicated, is only part of the picture, and that clinical controls need to be in place. That should include comprehensive programs, available and accessible to patients. These include things like behavioral health, behavioral health coaching, lifestyle services such as nutrition or fitness, and active and ongoing support that extends beyond treatment into ongoing years to strengthen and reinforce those better habits. A lot of studies indicate that half of patients who stop drug therapy experience rebound weight gain at or near their original weight. So this is even more important to ensure that patients that achieve goal weight loss and actually stop therapy can maintain that weight loss going forward. As this is a hot topic, we've got some bonus strategies for obesity management on the next slide as well. So looking at treatment themselves, we shouldn't just be focusing on the prescription side. The medical benefit, or even an employee assistance program, for example, is often where members, seek coverage first, whether that be nutritional counseling or dietary consults as well. So we need to make sure we look at all areas to ensure a holistic plan. For example, if obesity is limiting a patient's ability to become more active, physical therapy or even occupational therapy coverage may be something to evaluate and potentially enable a more active lifestyle for a plan participant. In terms of drug selection, an issue right now is that around 40% of the U.S. adult population is obese, and estimates indicate maybe an additional 30% overweight. So that means 70% potentially of the U.S. adult population is eligible, for an anti-obesity medication. And because of this, there's a large market currently available, and really we're nowhere near saturation. We're seeing for the plans that cover anti-obesity medications, maybe about 5 to upper end 10% of plan participants are actually using one of those drugs. This means that because the market is so huge and growing, there's less incentive and maybe willingness to compete on price between really the three main GLP-1s currently approved for weight loss, and really only the two main drivers. However, as more drugs become approved, this is going to be a very highly competitive market. So we could actually see, more competition, allowing for a narrower selection of preferred drugs at a lower net cost. And then going hand in hand for covered anti-obesity medications, there always should be, robust clinical requirements, such as proof of eligibility via labs, measurements, medical records, and not just attestations or simple checkboxes on a prior auth form. Plan sponsors can put in guardrails, and these can include higher BMI requirements instead of the standard 30, maybe raising it to 32 or 33. Age limits on drugs. So, for example, for Wegovy that recently got its cardiovascular risk reduction indication, the study population was 45 and above versus the FDA-approved indication is 18. So maybe you restrict it to that older age group that are at higher risk and more likely to benefit. And you could change in cost share that we talked about, or even consider requiring participants to utilize and show adherence to non-drug therapy first for a certain number of months before allowing coverage of drug therapy. And these are just, a few examples. Also, in covering these drugs, we should target overall outcomes as well and should hold plan sponsor partners accountable. So examples of outcome-based metrics, are adequate dose titration, reaching goal doses, medication adherence. So for the weight loss drugs, for example, there's a starting dose to help a member build tolerance to the drug, but it's not really effective for overall weight loss. So we need to make sure we're getting members or plan participants into that goal dose area and that they're actually getting the most benefit, for the medication. Additionally, we should see over time reduced rates, hopefully, of comorbidities, whether that's diabetes or cardiovascular disease. So really, lastly, one thing to keep in mind is that this is, a very rapidly changing field. And while cost is a big factor, potential savings may not be seen for years, making outcome-based metrics even more important. Prior to Wegovy receiving its cardiovascular risk reduction indication, the main KPIs we looked at were maybe, from anti-obesity medications, percent of weight loss, 5-6%, maybe an overall decrease in medical costs over time. Now, though, in lieu of looking at these specific measures, we're looking at other potential clinical outcome metrics. So as an example, this includes whether or not, for members taking Wegovy for cardiovascular risk reduction, are we seeing those members having a reduced rate of heart attack or stroke over time for members not taking those drug therapies? And that should be, something to keep in mind. And it's key to examine this, or really any area, with a multimodal approach and from various points of view, and that fits within our consulting approach. Eric?
Thank you, Matt. That was such a smooth lead-in that I almost missed it. But we touched on this a little earlier when we discussed how trends vary by plan. What this slide captures is really the primary areas where we find value or have found value in having an intentional strategy and an ongoing focus. So vendor management, plan design management, population health management. It's always important to be wary of big claims of savings, of anyone just showing up saying, I can knock 10% or save you 20%. But our experience is that meaningful savings is still possible. And there is always an ROI in being actively engaged and intentional in these spaces. The specific approach, the details, that's going to vary by plan. It's not a one-size-all thing. There's no magic bullet. Which is why data and analytics is right there in the center here. It's also in the center because this panel is 2 actuaries and a data scientist. So, of course, data is the answer. But on that note, let's move into some questions and answers, or maybe answers. I think we're doing pretty good on time, so we should be able to get through some questions. We addressed a lot of the questions that we received in advance within the deck. We worked a lot of that in. And I know a lot of people wanted to know who they should vote for next month, but that was outside of the scope of our survey. So we won't be giving any answers on the election. So I haven't been monitoring the chat. I don't know if Jason or Matt, if there's anything that's shown up that would make sense for us to address.
Yeah, so we got a few beforehand that we can get to, but let's start with what we got during the presentation here. I'll start at the top. The first one says, can you please explain the last bullet in more detail? Unfortunately, I didn't catch when this went in the chat exactly. I think it was slide 6. So do you want to jump to slide 6 and we can address that? And feel free to correct me in the chat if that is incorrect.
Slide 6.
Yes, I believe the question was on that last bullet. So I don't know if you wanted to handle that. Otherwise, I'm happy to.
Yeah, so this is just, so most of these trend drivers are related to what we would call allowed cost or total costs. This last one is just a point related to plan paid amount specifically, just to the effect that as costs trend over time, the value or the share of total costs that would be made up of fixed dollar amounts like deductibles and copayments, that becomes less and less impactful over time. So if you haven't made plan changes, or if your plan is bargained in such a way where you're limited in what you can change over time, then the value or the impact of these fixed dollar amounts becomes less and less over time. So on a plan paid basis, you might see trends escalate over time just from a cost shifting from the member to the plan, if you want to think of it in that way, in the absence of plan changes. So that one is a little bit, I don't want to say confusing, but it's a little bit different than the other bullet points that are on the slide. So hopefully that cleared that one up.
All right, thanks, Eric. Yeah, hopefully that was clear. Moving on to the next one here. So this says, what does your data show for companies covering GLP-1s for weight loss unrelated to an obesity diagnosis? So I presume for this one, it's just, what's happening with plans that cover GLP-1s for anti-diabetic reasons, but not for anti-obesity. So I don't know, Matt, did you want to take that one? Otherwise, I'm happy to as well.
Right, yeah. So I think we touched upon that, and yeah, if that's the correct interpretation of the question for plans that cover diabetes, GLP-1s, but don't cover weight loss, what's happening? And yeah, it really comes down to how robust is their criteria. So for plans with no PA, for example, yeah, we saw up to a third of utilizers appear to not have diabetes, and we're using it for weight loss. So essentially a 50% increase in cost. But that varies greatly depending on the degree of the PA. If it's, a simple attestation, obviously it drops a little bit, but it's still pretty high versus documentation via medical records or lab buyers that confirm a diabetes diagnosis, then obviously it's pretty much no at that point.
Yeah, just as a reminder, everybody on the call today, I did see a hand get raised. We are taking all the questions through the Q&A tab. We'll try to get to as many as we can. And another question that came in that was part of our front end discussion. We did record the session today, and we will be sending the recording to everybody after the completion of the webinar. Thank you.
All right, thanks, Chris. Thanks, Matt. Yeah, just to add to what Matt was saying, GLP-1s, we know they can be covered for diabetes or they can be covered for anti-obesity. There is a lot of overlap between those two. So I just want to make that clear, since we showed costs for anti-obesity medications and we also showed them for anti-diabetic medications, they're not really additive. If a plan starts covering for anti-obesity, it's not like their costs would be expected to go up like what we were showing there, because some of that's going to come from the anti-diabetic side. There's a lot of overlap. We usually see 30 to 50% of members with obesity also have diabetes. So just to make that clear.
Right.
And then I think there was a question in advance too that would be good to get to if we didn't already. There was a question about how much of this trend was due to high cost claimants, or if we've seen higher trends and high cost claimants specifically. And I know you've done some analysis around that, Jason. I don't know if you want to speak to the effect of outliers and high cost claimants.
Yeah, so this area can be very confusing in terms of understanding trends, I'll say. A lot of times, it really comes down to how they're defined. A lot of times in vendor reports, it's a lot easier to define it with a fixed threshold. So we're looking at claimants over, let's just say $250,000 in one period versus the next. And the trends tend to look a little scary there. And a lot of that is just due to leveraging. But what we typically see, we've done a lot of work in this area, is that claims above 250,000, just as an arbitrary threshold, they're really trending the same as the rest of medical claims. But what you see all those claims from the previous period, instead of 250 whatever thousand, those are 7-8% more expensive. And then all these other claims that were slightly below that threshold are also over that threshold now. So it's really the high trend a lot of people see in high cost claims is really due to frequency, just from jumping over that threshold. When we look at things like the top 1% of claimants, which kind of removes that leveraging effect, it's been remarkably stable. Over the last 5, 6, 7 years, the top 1% of claimants have been about a third of all medical costs. We haven't seen any significant changes there. But the important caveat is that they're very volatile. It really depends on any individual plan's experience, especially for a smaller group. If they see something like a gene therapy claim or multiple myeloma or leukemia or some other really expensive high cost claim, they're going to see a much higher trend than general medical inflation. And their general medical trend, I should say, is probably going to be higher than what's expected just from that one claim.
Yeah, and I think. Oh, go ahead. Finish your thought.
I was just to summarize, high cost claimants are trending just like other medical claimants. They're just a lot more volatile. So there's gonna be a lot more range there.
And I would say, just to add on to that, that's why it's really important to, try to identify what is driving those high cost claimants. If it's an astronomical cost and it's a sickle cell disease patient, then maybe actually that's the perfect candidate for gene therapy, right? So it may be a couple $100,000 a year over year, and the gene therapy might be 2.2 million or something, but that'll eventually hopefully offset that cost. So it's definitely something to consider. And I think now gene therapies they're continuing to increase in cost. I think the most expensive one now is $4.25 million. So definitely need to understand, what is driving those claims.
Yeah, and I think the thing about high cost claimants, what I don't like about seeing it split in reporting is a lot of times it's used to sort of distract people from true underlying cost drivers. Like you'll see a report that splits it by, oh, well, your trends might be 10%, but if I take away high cost claimants, it's only 4%. And it's your high cost claimant trend that's really high. And what that's capturing a lot of times is that leveraging effect that Jason just described. And what the interpretation that a vendor may want you to take away is that this is beyond their control. This is just outlier events are trending and they can't do anything about that. But that doesn't really give you insight into what's driving those costs, or it's in a lot of sense, all they're capturing is a somewhat meaningless effect, and they're not really giving you true insight. But Matt just brought up an interesting point. This really wasn't one of the questions, so I'm just going to upset both of them by asking one myself. Is what are we seeing in gene therapies? Just real quick, is this something we're seeing a lot of utilization in gene therapies today? Is that in some of the trend numbers that we were showing today? And do you think it's in some of the projections for the future, or not having a big effect?
I'll answer this first, and then Matt, you can always chime in. But we're seeing very, very low utilization. So it's kind of all over the map. In terms of driving something like high cost claims, it's a tiny percent of what we're seeing. I think it's about 1% of our claimants over $500,000 are due to gene therapies. So it's a very minimal impact. But we've also seen it in smaller clients where it's increasing monthly costs by $30 per participant, which is huge. So it really just depends. But I think at this point, the utilization is just really low. Even for a lot of people with these conditions, we're not seeing uptake yet. It's changing rapidly, though. There's hundreds in the pipeline through the next few years. And some of the indications are much more broader, things like osteoarthritis, cancer, things like that. That's going to have a bigger impact. We're not quite seeing that yet, but again, that's just in the populations we cover. Since they're so rare, sometimes it comes down to demographics, whatever it may be. So it could be high impact in other areas, but within our clients, it's pretty minimal at this point. But we're starting to see them pop up. I wouldn't call them a major driver of trend by any means, except for those particular plans that do happen to get hit and have smaller populations to kind of broaden that, to kind of soften that impact. It certainly can be impactful, but just generally speaking, it's been slow to get going.
Yeah, I would say, I don't think it's for a lack of willingness to cover these therapies. It's just that it's a very, very confusing and complicated area. For the sickle cell disease drugs, there's two specifically, one 2.2 million, one 3.1 million. They're not available at all locations. There's specific facilities throughout the country that will only administer those medications and other areas not. So you have to think about whether we need to cover a travel benefit on top of that. The $3.1 million cost that I quote is just for the therapy itself and not for the ancillary, pre-infusion treatments, the post-infusion treatment, all these other scenarios. So it's complicated to try to develop the program around it, and that's why I think we're seeing some of the slow uptick.
Yeah, nonetheless, though, plans need to be ready to cover these, either with self-funding reserves or having a stop-loss policy in place and making sure that stop-loss policy does in fact cover those if they do happen to hit. It's very important because I think eventually every plan is going to experience one, and it's kind of hard to detect, when that's going to happen. So certainly get ready for that.
Well, on that optimistic note, I think we're at time. So I don't know if there's any last.
There's only one more question, so I might as well answer that.
Go for it.
And I guess I'll take it just from what I've been seeing. Certainly, either you two can correct me, but one of the questions was, are we seeing any impact due to plans footing the bill for the COVID vaccines? And this was a huge area of concern, once the government removed funding for those, because prior to the government paying for them, plans were only paying about $40, and that was just for the administration of them. And we saw heavy uptake right away. So if you started doing the math on what those vaccines were going to cost plans, once they had to start paying for it, it led to some pretty scary increases in trend. But what we have been seeing is that uptake has been very low. Utilization has kind of plummeted from that first year. So even though the cost for plans went from $40 to a couple $100, the overall cost has actually gone down for most plans I see. So it's actually been a deflator in costs. But that's not just from the cost shifting, that's just from the utilization just dropping a lot. We're not seeing uptake like we are with the flu vaccine at this point.
All right, thanks, Jason.
Yep, you're welcome.
So I think that's it for today. Chris, I don't know if you had any last things to say or
I
you know,
think
you
we're
can-
set. I know, the the presentation was recorded today. We'll get that out to everybody as soon as we can. And thank you for joining us.
Yep, thank you all.
Thanks, everyone. Enjoy the rest of your day.